Can you tell us how you got interested in clinical psychology?
It's retrospective, so it's been tarnished by having thought about it a few times and some inaccuracies thrown in because cognitive recall is always that way. But my best perception would be a high school class. Went to an all-boys private school. It was academically prep-oriented and kind of, rigid learning of a variety of things. And we got this one class. It was called religion. It had nothing to do with religion. But it was really psychology. It was a dash of psychoanalytic thinking, a dash of more Rogerian kinds of thinking, some problem solving. But it was about the human mind and human behavior and really interesting. And just by chance, the instructor's name was Philip C., his name, and I'm Philip C. Kendall. So it's like we clicked, and I said, oh, hey, that's cool. And we talked for a while. And he was one of those super smart guys who chose a religious path in life and went on to argue, this was a Catholic school, went on to argue with the Pope about education should come first and it shouldn't be restricted as to what can be taught. And when they were trying to rein in some of the programs in our high school, he went to Italy and made his case. And I always thought highly of him for having done that. So it's interest due to exposure to the topic, interest due to it being appealing to me, and then also a very likable individual who put it to good use. Mm-hmm. I think also a college instructor made a big difference. You're in class and your roommates and friends are with you, and no offense to my roommate if he ever sees this, but he got a better grade on the first test, and I thought, I'm smarter than he is, So I started, reading the book, and the answers to the test are in the book. It's amazing. And so I think an early course in psychology that included how to measure impulsivity and how to measure reflective thinking, and the measure that you actually use was in the book, and I remember being impressed with that as a psychological notion. So that was good. And I think also being a product of the 60s, I wanted mental health services to be other than drugs, because I had a good friend who died from a drug overdose, and drugs ruined a few friends. So I was keen on options to medication.
Mm-hmm. So I guess related to that, what started your interest in cognitive behavioral treatments?
I think because I was taught first in learning theory. In fact, there's a book on the shelf over there, and it's yo thick, and it's by a man from Rutgers University, and it's on learning theory and methodology. And was it detailed and difficult. It was a graduate textbook. But because my instructor had gotten his PhD at Rutgers and knew the book, he used it for his undergraduate course. And I took it seriously, and I learned that damn book, But anyway, everything about learning theory appealed to me, because it wasn't this magic hocus pocus of change. It was the research based on animals and humans that told us what factors influence behavior change. So it's like the science of behavior change. And that to me was early behavior therapy. So that made a big difference. And I did research with animals. My first couple of studies, we had mice in cages and stuff. That's the sample that we used. And we studied some avoidance, actually, and exploratory behavior, conditioned safety, and things like that. So it's kind of cool. But humans think. And so I had options to go to graduate school in learning theory in a variety of places and chose clinical, because humans think. And so I wanted it to be a little bit more than just a pellet at the end of the runway. And so for me, cognitive behavior therapy was like a perfect match of the human side of learning theory. And so for me, that was a real turn on.
Yeah. And then who are some of the most important influences in your career?
Oh, this is the worst question to be interviewed on, because I'm going to forget somebody. And I can't edit this. Somebody else is going to edit this. And so somebody's going to say, well, you didn't mention me. So I'm tempted not to mention anyone. On the other hand, an undergraduate instructor, Pete McCulka, was influential. In graduate school, Al Finch and Don Kiesler and Bob Ney and others were very influential. My graduate student cohort, other guys that I went to graduate school with were influential. But I got my PhD and then got a job at the University of Minnesota. And I almost went to graduate school again, because I would sit in on Paul Meal's class or learn from, Jim Butcher, because the faculty there was spectacular. So I was still in school. So a long list. And I'd be remiss if I didn't mention that I had the opportunity to be at the Center for Advanced Studies in Stanford when I was 27 in 1977. And there were some fellows there, people like Terry Wilson and Al Kasdan and others. And then I got to work through a project with Marv Goldfried. And that's all influential. You can't pick a name, and I'm sure I forgot somebody. So person X, you're in there too.
Everybody's represented. What are your most important contributions to research and practice in clinical psychology?
Oh. I think by numbers and by brand name, the coping cat. I think that's a little bit simplistic. The brand name, yeah. By recognition, yeah. All that. But I think the notion of mental health services for kids are not play therapy. It's easy for the therapist and kind of fun, but not as effective. It's not pure behaviorism where you're given M&Ms for specific things, but that it's a process that is at a developmental level that allows kids to learn some skills and then practice them, get rewarded along the way, and come out doing stuff, quote unquote, that they couldn't do when they started. So I would say that's a contribution, but the brand name is probably what people would pick up right away. I think randomized clinical trials, they're kind of expected, if not overused, as an approach. But back when I designed a study as a potential dissertation, it was not. And I was fortunate to work with Don Kiesler, who in 68, 69 wrote about it first. It was, a grid model. What are characteristics of the kids or patients, characteristics of the treatment, characteristics over time that predict outcome. And with real patients, you don't do it with a snake-phobic college student, you do it with real patients. So I think that's a contribution. And when I edited JCCP, I was really keen on RCTs that were well designed. My fussy side came out, and things had to be done well. And so I think that was a contribution. Computer-assisted treatments and online parent training for anxious kids, coping cat parents, stuff like that I think is cool. And I mentioned JCCP, but I actually edited a little bit for behavior therapy, cognitive therapy and research, JCCP, and then clinical science and clinical psych science and practice. And I think that's an area I contributed. A lot of work, a lot of time. Excuse me. Don't ever calculate pay per hour because you'll be very disappointed. It's depressogenic. But it was a service that I think allowed the field to move along nicely.
Great. How can we do a better job of disseminating CBT to clinicians?
I think the answer is really an empirical question. We don't know. And there's a graduate student here and some others working on it. Recent graduate student who's now over at the University of Pennsylvania working on it. And we're all working on it because if 20 therapists in a particular study do a really bang-up job, spot on, and the kids improve, that's great. But if there are 20,000 people, and if some of them could learn it too, that would be even better. But taking it to scale, or disseminating, has some challenges. So I would say the following is an option. Rather than take people who are already skilled at whatever they do, or well-practiced at whatever they do, get people before they've entered into the workforce. In other words, think of it not as retraining practitioners, but think of it as rolling out a new workforce where all graduate trainees would be trained. Makes sense. If a treatment works, you put it in graduate school. If it doesn't work, you don't. And then everyone who's doing everyone who's going through graduate education and all those programs being overseen by agencies that oversee graduate education would require that treatments that work are taught. And over time, we'd get there. I think the retraining has a snafu built in, and that is there are some biases and some hesitancies and maybe even lack of knowledge. I have a couple of things I bet on. One is if someone performs exposure with kids and helps them face challenges and sees how effective it is, their attitudes change, their behavior changes. That's good. And if they recognize that CBT isn't a manual, that it's a flexible approach, I think that would be good. So some flexibility, some experience with it, and train the workforce to implement programs rather than try to retrain too much.
Mm-hmm. What do you believe are the biggest challenges facing clinical science in general?
The differing numbers of people who are trained in the two parts of our profession versus the number of people who are trained in only the one part of our profession. And the fact that a mental health clinical psychologist has expertise in performing research but also interpreting and using its findings, and they have skills at application. I can't give you the exact number, but it's a disproportionate imbalance of the number of people who have a ton of different degrees from a ton of different variety of quality educational opportunities who then just do the practice side, or maybe even a small number who just do the science side. But the number of balanced appliers of new knowledge, that disproportionate number of people, that's a challenge. And I think maybe part of it, and I wouldn't have said this 20 years ago, but maybe part of the solution is a policy change where you no longer allow graduate institutions to receive credentials or certification unless they're teaching what we know or have learned to be appropriate procedures. They do it in medicine all the time. They do it in dentistry. They do it in law. You know, why do we allow our field to kind of be soft and sluggish?
What recent findings about psychopathology and mental health are likely to have the greatest impact on future research and practice?
I don't know. You're asking me to predict the future. I can't do that. The Cubs just won the World Series. That's hard to predict, you know? I think I'm going to have to pass on that one and just say findings that are from a good study, that are communicated not in a righteous manner but in a collaborative manner, in a way that most people can understand and accept, are probably going to be effective.
And you already touched on this next question a little bit, but what changes would you want to see in graduate teaching and training in psychology?
One, a course in learning theory, or a course in human learning, or a course in factors that influence what is or isn't learned and how behavior changes over time. That used to be in graduate education, and it's not anymore. And it's unfortunate that governing bodies like APA have chosen to require a course in something like supervision when we have no science base for a course in you can sit and talk about it, but we don't have a basis for it. Learning, we have a basis for it. So there's content that's being ignored for something that's the political ripe topic, and that shouldn't be how education is determined.
Mm-hmm. And then how do you see CBT evolving over the next 10 years?
Good and bad. I think the good news will be dissemination and implementation will help get it out there. I think this recent neuro twist will get us some data on brain images before and after. I like that. That's cool. On the downside, you have attempts to encourage implementation of CBT by saying if you don't do it, you can't get reimbursed. And so then the person who's providing says they do it, but they don't, or they may not do it well, or they may not do it fully. And so you have endorsement of CBT entering into a database that has never been checked for whether it's actually provided or not, which is going to lead to misleading conclusions.
Mm-hmm. And then what areas or issues do you feel CBT needs to address more in the future?
Issues. I'd say maybe some more ongoing supervision following these quote-unquote training workshops or efforts to learn CBT on the part of practitioners, which is to be encouraged, but some follow-up to that. I think the real skill comes with ongoing supervision and consultation and practice. Mm-hmm. No surprise there. Can't play the piano without practice, and your teacher gives you feedback. So.
Yeah. And then last question, how has membership?
Last question.
Yeah. How has membership in ABCT impacted your career?
I think for me and for many like-minded people, ABCT, formerly AABT, it provides a home. It provides a place where you can be stretched, but also where you can be supported. And I like that. It's a convention that's a training event every year. It's a source of journals and a source of information online for the public. And I think ABCT has taken an educational posture. Every time, when I was involved in leadership more actively, every time we'd have a retreat, we'd say, all right, what's the mission and how are we going to achieve our mission? Because you can't talk about what you're going to do till you first agree on a mission. And the mission was never to make more money or to do X or Y. It was always to better educate and serve our group and the masses who join. And when you take that posture, it helps tremendously. It's a good way to make a training event that is useful and that people enjoy coming to.
Awesome.
I think it's also, ABCT has also been two things. One, it's been really cool for me because I got to meet all these big names, you know. When you're a graduate student and you're reading, you go, oh, for example, Bandura, you know, and then you meet him and you talk to him. And for me, I could name 20 names, I don't want to leave anybody out. But you meet people and you talk to them and you find out they're struggling with issues just like you are. And it's nice to be on the inside of a process as opposed to glorifying or reifying these named individuals and stuff. That's cool. The last thing I'd mention about ABCT that during my term as president was, you know, we bought a space for the building in New York, and I think that literally and probably also figuratively is a home, and it's an accomplishment for an association to do that, and that reflects our stability as opposed to a whimsical society that comes and goes. We're here for the long term.
All right. Thank you, Phil.
You're welcome. Hope I didn't leave anything important out.
Fingers crossed.
Yeah. Thanks.